Good afternoon, everybody. We kept the lunch light, so you should all stay awake. Now, our order of importance is we have two very terrific speakers for our afternoon session. Before I have a pocket load of questions to thumb through, which we'll never get to answer all. But without further ado, it's my pleasure to introduce Dr. Srdan Verstovsek from MD Anderson, and he's going to answer some of the questions you're all very anxious to know about what's new in the future and what's coming down the line.
It's a great pleasure and honor to join you again for this meeting. I really cherish the experience in this kind of setting where we, like it was emphasized earlier on, have the opportunity to exchange in close encounters your experience with our experience, so physicians and patients can work together to improve what we do together, because it's after all a team effort, including the pharma, the companies that are involved in the clinical trial developments. So this is a wonderful, unique opportunity, so thank you for that. Now, it is after lunch, but I'll try to keep you awake and perhaps show you some cartoons along the way. No kidding, to explain the very difficult topic. And I am following the outstanding presentations this morning, one better than the other, but I would like really to emphasize that we had a special opportunity to hear Dr. Hasselbach here in providing us where the future is going. The vaccine thing is incredible. We have not thought about this at all until more recently. And I wonder whether there is opportunity for Dr. Hasselbach to repeat his talk later on in the afternoon, because there was so much in these 20 minutes that I still struggle to put it all together. So thank you very much for that. So I'm going to try to simplify it to the level possible and explain really in a simple terms, but this is my plan of action here. I'm going to talk about super long-acting interferon. We talked about interferons already, and it was already mentioned that in Europe there was a development of Ropeginterferon, a new type of interferon that is given under the skin every 2 weeks with better tolerance and better efficacy than any other interferon so far. And I'll just summarize what is this all about and where do we see it in terms of getting it here in the United States and what the plans are. And this kind of assessment I'll do for many other attempts to improve what we do, to explain where we are and what is going on in general terms, and try to not emphasize too many drugs, but those that are of the most importance for us. And I hope my English is good enough for you to understand. They say I'm from Texas for 25 years. 25 years with heavy Texan accent mixed with Croatian. Who is going to understand this? Nobody. All right, so let's start with the Ropeginterferon, right? Super long acting for me because we utilize Pegasus. Pegasus is the one that is given weekly. And it's off-label use that we use in younger people in particular, in ET and PV, and early stage myelofibrosis. But the new important development is this particular study comparing in polycythemia vera patients Ropeginterferon with hydroxyurea. So early intervention rather than late. And this led to approval in Europe, in European Union, of Ropeginterferon for polycythemia vera, based on complete hematological response. This is the second bullet on this table. CHR means complete hematological response, normalization of the blood cell count, white cells, red blood cells, and platelets, in patients that do not have big spleen, because the spleen is not very well controlled with the interferon. So this is where we are with the Ropeginterferon. The study that led to its approval is this one. This is important to understand because we are hoping that we will have that medication approved here in the United States in very near future based on these results without doing any other study. There are active negotiations and understanding between the regulatory bodies here in the United States and the Pharma Essentia. Capable hands of our colleagues in the Pharma Essentia company are leading this effort to have it here for our patients in the US. So as you see, From the left to right, patients were randomized between the two medications, Ropeginterferon and hydroxyurea, initially for 12 months. This is in the middle of the slide. And then, and that was a very smart move, the patients were continuously observed for a prolonged period of time, up to 5 years of therapy. And this is exactly where the key information comes from, because interferon, as we now all know, takes time to work. This slide was shown before. What I'm showing here is complete hematological response, normalization of white cells, red blood cells, and platelets. And in a red line is percentage of patients that had normalization with interferon, and in a gray line is with hydroxyurea. Hydroxyurea works faster, but then the maintenance of the response is not very good, while the interferon takes longer period of time and it gets better and better and better. That's actually what we want with a chronic disease. We would like to have both rapidity and continuous increase. We don't have immediate effect, but we have continuous improvements over time, and more patients respond longer you treat. And we have a celebration music going on right now, so that's great. And this is no less than from Dr. Silver. It's newspapers calling already, Dr. Silver. All right. How about the safety? You need to deliver this medication for a long period of time, right? To get the effect, and people live long with the PV or ET. And so the safety is very good. As you see, the comparison between AOP, that's the Ropeginterferon, and Hydrea, you have much less of suppression of the blood cell count. You do have some difference in the GGT, which is the liver function test, but otherwise appears to be a really safe drug for a long-term delivery. In fact, after first year of therapy, you switch from every 2 weeks injections to once a month. So it's even simpler. So this is why the drug was approved, and we hope to have it here in the United States soon. The exciting part is, although I know Dr. Silver said that there is no, at the moment, and I agree with him, a clinical relevance to decrease in the number of cells that have a JAK2 mutation. That's what the JAK2 allele burden is. When we talk about the JAK2 allele burden, that means how many cells in your sample have a JAK2 mutation, right? So the numbers differ in different patients, and what this study showed is that the number of patients that have a decrease in the JAK2 allele burden, the number of cells with the JAK2 mutation is decreasing on them. They have molecular response. The number is increasing over time. This was the hydroxyurea here. So longer you treat, more likely is that there is also molecular response. And hopefully over time, if we continue this way, we will, I see Dr. Hasselbach is nodding here, he agrees with me, that we will eventually see that the molecular response actually have a clinical benefit to a patient, which we don't have yet. So I'm looking forward to see more of this. So that's on interferon. I know that we will have questions later, but we'll go from one topic to another. Okay, let's move on to myelofibrosis. This is about 15 years old slide. This is how we understood what is wrong with the myeloproliferative neoplasms. This is the cell from inside. You see, this is the blood, or outside the cell. This is the membrane on the cell. We have these proteins on the surface of the cells, which we call receptors. The protein that goes around the blood, cytokine, growth factor, there are numerous names to it, bind to the receptor and activates the signaling pathway that tells the cells to do something. We call this JAK-STAT pathway or highway. I had a patient explaining to me that it's easier to understand that once you activate these JAK proteins and then JAK proteins activate the STAT, why don't we call it highway? Okay, it's a highway that it's active occasionally in a normal person when we need to make blood. It's also involved in inflammation, and it's also involved in immune function. It's not only present in the bone marrow cells. So this JAK-STAT highway is important for multiple body functions. And there are multiple different JAK proteins. There are 4 of them that we know of that may be associated with different receptors for different proteins. That's how the body functions. And in myeloproliferative neoplasms, there is a mutation either in the JAK2 protein or in the receptor itself, or in what we call calreticulin protein, which binds to the receptor from outside and activates the highway. So there are 3 different ways that highway is active all the time in patients with myeloproliferative neoplasms. Either mutation in the JAK2, mutation in the receptor itself called MPL, or calreticulin protein, which is binding from outside to the receptor and activates the JAK-STAT pathway. So once we learn that, we say, okay, we need to develop medications that will inhibit the JAK-STAT pathway. Okay, that's, I hope now easier to understand. So we developed JAK inhibitors, yes, to inhibit the JAK-STAT pathway. Okay, JAK inhibitors are not specific for any mutation. They just inhibit the JAK-STAT pathway. What is going to happen if you inhibit JAK-STAT pathway? The number of cells will go down, the inflammation will go down, immune system may be modified to some degree, right? Because the JAK-STAT pathway is important in cell growth, in inflammation, and in immune function. So when you develop the JAK inhibitors, you may have less of a cell growth, which is smaller spleen. You may have less inflammation because people feel much better, walk much more, gain weight. And immune system may be modified to some degree, which we know may happen with some unusual infections in people on JAK inhibitors. Please interrupt me if you don't understand me. Just raise your hand. Okay. But we are unlikely to eliminate disease, right? We are inhibiting JAK-STAT pathway, which is super active in patients. And this is what you get then. What do you get clinically? That's a patient of mine who came, that was at the beginning, right? What do we have in myelofibrosis at the advanced stage? You have very big organs, spleen and liver are enlarged. And what else you have? Weight loss. You see the ribs here. This patient came in a wheelchair, bone aches and pains, night sweating, low-grade fevers, all those systemic symptoms. Performance status, that means how active you are, goes down. Unable to function anymore. That is the advanced stage myelofibrosis. With inhibition of the JAK-STAT highway, you get less of a growth. You see less of a spleen and liver, right? They're still there, but they're much less prominent. And what else you see? You don't see ribs anymore because patient gained weight. This patient now was able to walk. Symptoms went away. And he functions again fully as a normal person does. And I know there are many patients here that are on JAK inhibitor ruxolitinib. Anybody had similar experience like this? Over there is one. Not yourself, Dr. Spivak. In your patients, I would say. Any patients here that had similar experience? But this is what happens typically. So you would say, why not in everybody and why not forever? And why not more than 3 years on average, like it was said earlier on in the clinical studies, it was 3 years so far. Okay, why is this happening? One more time, why is this happening? Because there is inhibition of the JAK-STAT highway, there is less of a growth and less inflammation. Okay, 2 benefits of the JAK inhibitors in general. Anti-inflammation and anti-proliferation. That's why less cells and less inflammation, so you feel better. The inflammation is usually related to cytokines. These are proteins that are produced in the bone marrow or otherwise in the body, partially from the malignant cells, partially from the bone marrow cells that support the growth of malignant cells. And I'm sure that this is all known to you. I'm just summarizing for you what you already know. Right? See, I know. Okay, so where are we with other JAK inhibitors? We heard about ruxolitinib and fedratinib. Dr. Hoffman was summarizing for us. Fedratinib was approved in August for therapy of patients with myelofibrosis. They both decrease the spleen. They both improve quality of life. They may have a little bit different toxicity profile. You heard about neurological toxicity with fedratinib. But they are there now approved, right? What's happening with the others? Pacritinib is the one that is being now studied in the randomized study. That's called phase 3 studies are randomized studies. It's going to be randomized between pacritinib and best available therapy, whatever the doctor wants, for patients with platelets below 50,000. This drug does not suppress platelets much. It can still improve the spleen and symptoms. So the goal is to develop it as a therapy for patients with low platelets, for which you cannot usually use ruxolitinib and fedratinib, and see whether their spleen and symptoms will improve. This study is at the beginning, and it's going to be throughout the United States and the world. The other one that is of interest is momelotinib, another phase 3 randomized study between momelotinib and another drug called danazol, which we use as anabolic steroid to improve patients' symptoms and anemia. This is very interesting. This drug is less spleen active and more symptom active, and perhaps also improving the anemia, which is counterintuitive, but it seems so. Perhaps it's because it's more anti-inflammatory. Inflammatory agents like prednisone can improve the anemia, so the goal of this study is different than any other study with JAK inhibitors so far. It will be for patients failing ruxolitinib that are symptomatic and anemic. These two studies are to watch because they may lead to approval of one or these other drugs within 2 or 3 years when they finish, and we may have more JAK inhibitors. So these are the drugs that aim to inhibit JAK-STAT highway, right? This was 2017, actually. Now this is old. Anybody here can see the JAK-STAT highway here on this cartoon? The old one was 2005. This is 2017. It's incredibly complicated. So much is wrong in these cells. This is the JAK-STAT highway here. There are other side highways that are active. There are other abnormalities that may be abnormal in these cells. There are abnormalities in gene expression in the cells where the DNA is. There is a whole area of different abnormalities. We thought we had it when we identified the JAK2 mutation, and this is where we are at right now. It's incredibly complicated. So much is wrong. And all these boxes here, these are the names of possible drugs that can be utilized to inhibit these other problems. You don't need to learn all of those names, it's too much. But just to give you a sense what's wrong, it's so much wrong, right? Okay, so what can we do about those? We can study those medications. And I just give you the names as a general view what the names of these drugs are. Again, not to learn the names, just to have a sense that we know there is so much wrong, and there are so many other medications that can be used to treat or to develop them as a therapy for patients with myelofibrosis. You can combine them with ruxolitinib, for example, or you can study them alone after ruxolitinib, if ruxolitinib doesn't work anymore. And this is continuous flow of new medications. I give you even not the names of the drugs, just the groups of the drugs, like types. Everything is on clinicaltrials.gov. That is the site where you go and you search it like any other, like a Google, basically. Put the keywords and say myelofibrosis, ruxolitinib, or investigational agent or not. You will find everything there. Clinicaltrials.gov. For example, at MD Anderson, at the moment, we have 9 different studies, but 5 of them are adding medication to ruxolitinib. Others are after ruxolitinib. And if you come to see me 6 months from now, these 9 will change to some other number with different drugs because it's continuous testing and evolution of our approach how to develop new drugs, targeting other abnormalities other than the JAK-STAT highway. The other issue is who should be the patient that we study this medication in? The patient that I showed you a photo of had obviously extraordinarily good response, right? Should we add another medication in this gentleman to completely eliminate disease? Is this reasonable to expect? Shall we wait for this gentleman to have a progression of the spleen and then intervene? What shall we do? What patients shall we test these medications in, and what are the expectations of these therapies? I can tell you, by and large, the expectations are not to eliminate disease at the moment. That's a very high bar. It's more realistic to have a synergism between the two drugs to boost what the JAK inhibitors do or bring additional benefit, like anemia. Anemia rarely improves with the JAK inhibitors, it mostly gets worse. So you would, for example, add medication for anemia to a JAK inhibitor. Elimination of the disease we cherish, but it's extremely hard to get it. So control of the disease and improvement of signs and symptoms is reasonable expectation. That means smaller spleen, better blood cell count, and improved symptoms for as long as possible, hopefully forever. That's the realistic goal. Yes? You agree? Excellent. Okay, we showed, and this was shown before, we have high hopes for these particular drugs, Sotatercept and Luspatercept, two drugs which are explained here, but it might be more or easier to understand what these drugs are. These are artificial constructs that look like this. They actually bind different proteins from the blood and catch them before they go into the cell, right? So these are called fusion proteins. They trap different proteins from the blood before the cells are activated, before they do something bad to the cells in the bone marrow, and that will allow red blood cells to be produced better. Remember, that was mentioned actually twice today. Early on, the first talk was on that from last ASH. Dr. Schiffer was saying about that. It's important to understand that this is something to watch for development as anemia medication, because we have some preliminary results that for patients that are anemic with myelofibrosis, you can add this medication to ruxolitinib or use it alone for anemia, and you may have good response. And you would say, well, it's only 35% response rate, but we don't have anything, actually. I would love this to be 95%, but we are getting there. 35 is good enough for now, 1/3 of the patients responding well. So at the moment, there is a large study around the United States of this medication in the luspatercept in myelofibrosis. We'll have initial results in December at the American Society of Hematology meeting to see whether we have a drug for anemia that will possibly be then developed soon to add to JAK inhibitors. All right, let's move to something completely different. Because we are trying to find new ways of tackling the disease, right? Vaccine was an amazing approach. What I have described so far is more or less common sense, right? What else is wrong in a cell? Can you tackle other highways or other abnormalities in gene expression? But then there is also a role for other cells in the bone marrow that are not malignant, but they are participating in the malignant process. So this is a very simple cartoon of a bone marrow. HCC, right? This one, this is a stem cell. That's a mother cell, HSC. From the mother cells, you get different types of other cells, but there are blood cells, right? There are mesenchymal stem cells that are supporting cells that make the bone marrow. There are nerves here that end in the bone marrow. There are many other cells in the bone marrow. We call this sometimes stroma, or we call this microenvironment, right? There are other cells other than blood cells in the bone marrow. And we know that they may be also involved in the disease itself. So if you put this in different cartoon, I'll call this microenvironment, you have here in a brown color a stem cell becoming malignant cell, leukemic stem cell, that's how it's usually called. That happens, and these are other parts of the bone marrow that are still functioning well. There are nerves here, there are bone resorbing cells, there are other cells that are supporting. These are all part of the bone marrow microenvironment. And this is what happens over time in the bone marrow of patients with myeloproliferative neoplasms. Everything gets out of order. The malignant cells predominate. The normal cells cannot function anymore. Fibers develop all over the place. And one factor that appears to be extremely important, that was highlighted earlier on, is inflammation. Those cytokines that I have mentioned earlier on, and that were highlighted in Dr. Hasselbach's talk. These are the inflammatory signals that come not only from the malignant clone, but from the environment, from the other cells in the bone marrow as well. And there is interaction between the malignant clone and the environment together. Others have written other reviews on this topic, trying to put this in some kind of a semi-intelligent way together in the graphs, and this is very good summary of what's happening. You see different types of cells involved, like monocytes here, megakaryocytes. You have all these cytokines. These are cytokines names. And the summary is here. Neoplastic clone is the main driver of the disease, but the inflammation and inflammatory cytokines contributes to the worsening. And it is also affecting the quality of life of the patients, we know very well. Constitutional symptoms, the bone aches and pains, night sweating, weight loss are related to the cytokines. So it's a composite of the proliferation and inflammation. And inflammation is coming not only from the malignant cells, but also from the microenvironment, the cells that are supporting the malignant clone in the bone marrow. So the question is, can you tackle that? Can you actually affect that? And there are studies that are being done. Please don't look at any of these graphs here. I'm just going to show you that as a flashpoint to say, yes, we are doing something about the microenvironment and not only about malignant clone. This is a study in mice, and then it was in men. Focus only on this in blue. That was a study that was looking to improve the ends of the nerves or nerve cells in the bone marrow. Just, it doesn't make sense, right? If you just hear that out of the blue, we're going to do the study with the sympathomimetic agonist. It would be to affect the nerves. For the patients with myelofibrosis, you would say that I'm a little crazy. But once you understand the biology of the disease and see that microenvironment and the different cells in the bone marrow are involved, then you say that might work. And what happened in the human and mice is the fibrosis actually decreased, but there was no improvement in bone marrow function. So there was no clinical benefit to this attempt. But it's out of the blue, different type of approach to therapy. So this is being done. Another drug that is being tested is the drug that inhibits the change of monocytes. This is another type of cells present in the bone marrow. I showed this before. They appear to change through malignant process to fibrocytes, fibers in the bone marrow, and the drug called PRM151 or PTX2 inhibitor may inhibit the formation of fibers, and that would improve the bone marrow function. This study actually concluded in men already and presented 3 months ago at a meeting saying that yes, in about 40% of the patients there is decrease in fibers, and some of these patients have some improvement in bone marrow function. That means the red blood cells and platelets increase. So I'm giving you a scope of work that is usually not really appreciated, that there are other ways of tackling the disease, not only focusing alone on the malignant cells. They will not exist in the bone marrow in a vacuum. Other cells participate in the process as well. And then let's move on to the immunotherapy. Outstanding talk earlier on about immunotherapy and how we can develop vaccines because patients with calreticulin mutation express on the surface, and I highlighted this early on, the mutated calreticulin, and no normal cells has it, no normal person has it, so it's specific for the malignant cells in the patients with calreticulin mutation. You can exploit that by developing specific markers or specific medications to kill or enhance immune system to kill the cells with the calreticulin mutation, right? That's about 30% of the patients with myelofibrosis or with ET. During that talk, Dr. Hasselbach also talked about immune surveillance, right? Our own immune system is normally able to kill malignant cells because they are not normal. What happens in the body of a patient with malignancy or cancer is that these T cells, these are the killer cells, these are the most important ones. They recognize malignant cells. This is a tumor cell here. But there is a defense system here, which is this particular part of the cartoon in the blue, that is preventing recognition, very well recognition of the tumor cells, and tumor cells stay alive and well in the body of the person. You understand this? It's kind of easy, actually. There is recognition, but it's diminished by additional processes here on the side that do not really allow T cells to recognize fully the malignant cells and kill it. There are medications now that are commercially available that disrupt this inhibition. These are called immunocheckpoint inhibitors, approved, several of them, for patients with solid tumors. And prime example is melanoma, where it's extremely active. We did the studies, 2 of them, and that was mentioned earlier on, in myelofibrosis, and it did not work. None of them did not work. We believe, and you suggested through your talk, Dr. Hasselbach, that the T cells itself are not able to work anymore. They're exhausted, and there are not too many of them to activate. And the immune system is just not good enough anymore in advanced patients with myelofibrosis for this kind of therapies. But maybe they may be combined with vaccines. So like you said, this particular approach was very attractive because it's commercially available medications, but it did not work. Now, let's move on to something else. Many of you, and I have patients coming through the door and say, why don't I get CAR T cells? Anybody knows what the CAR T cells are? It's this is where it is described in this cartoon on the left side. T cells are these killer cells, right? These are the T killer cells. And number 1 here, you collect T cells from the patient, right? You get them from the blood with the machine. You can isolate white cells and get T cells out of these white cells. These are white cell types. Then number 2, you can engineer them to have on the surface specific construct that will help recognize malignant cells in the body of the person. This is called CAR, right? Chimeric antigen receptor. This is number 2. Everybody follows? Okay, so I have patients coming and they say, why don't I get that? Right, so yeah, we can get the T cells from you. We can then engineer them in the laboratory, but what are we gonna be engineering them against? We don't have anything specific on the malignant cells in myelofibrosis. Maybe the mutated calreticulin in patients with the calreticulin mutation, because it is on the surface of the malignant cells. What else? And then what you do, number 3 is, once you do that in a laboratory, a little engineering here and there, you develop these T cells. They have this specific construct on the surface, so that's why we call them CAR T cells. You infuse it back to the patient. And what happens in a patient? This particular construct in blue would be recognizing malignant cells that have compatible marker, and that would be killed, right? It would be killing that malignant cells. We don't have this yellow marker. We don't have specific marker on the malignant cells in the MPNs, except maybe the calreticulin, mutated calreticulin in patients with the calreticulin mutation, right? So we can certainly do all of this, except we don't know what to make these T cells for, right? And so this is where we are stuck. This is readily available otherwise as a technique, and it's being developed left and right for many different conditions where there is a specific marker on the malignant cells or semi-specific marker that would preferentially kill malignant cells. But we don't have that in MPN. Are you doing anything like this for a calreticulin mutation? Not yet. But that would be the population of the patients where that might be possibly useful. Yeah? Okay. And then people also go and read, and I'll put all of this at the same time. They say, how about we cut out from my malignant cells what's wrong? Right? Gene editing, all over the news. We're going to do this CRISPR-Cas9 technique. We're going to take your cells out of your body, put them in a dish, repair them in a simple way, right? What's wrong? We're going to cut it out and we're going to insert the normal, and these cells now in a dish will be normal, and we're going to put it back. And they will populate your body, and the other malignant cells might die off or something like that. And that something like that is the problem, right? Okay, because what this is useful at the moment is for genetically inherited conditions where there is underlying, you're born with something that is leading to metabolic problems that you can fix with replacement in population of the cells in the body and give it back to the patients, and that new cell population will be good enough to supplement what is missing otherwise in the body. Here, first of all, it's not genetically simple. I showed you the 2017 cartoon, so much is wrong. It's not only one. And the technique itself has problems. That problem is the last bullet. You may not always succeed in doing what you're doing. You may do something wrong. So it can be cut out, something else can be cut out. So it's not bulletproof technique. So you can induce some mutations instead of correcting a mutation. So it is not, for multiple reasons, as you can see, ready for prime time at all in MPN, right? It's being worked out for specific conditions that you are born with, that all your cells are not producing certain protein or enzyme or things like that. Thalassemia, for example, that you are born and you can put corrected cells back in the body of a patient, and that would be good enough for the body to function normally. Not for MPN at this time, unfortunately. However, we are not giving up on a cellular therapy. This is a study that just opened at MD Anderson, and I'm sorry I'm over time, because this is very exciting. My last slide. Okay, what are we doing here? We are actually infusing patients with the T cells. We are. And you may say, I just said that doesn't make sense, right? Now, these are special T cells. These are from cord blood. These are from cord blood. They are immunologically naive. They are not specific for anything at all. They are not going to attack the body of recipients like otherwise would happen. They are not going to be killed. They're going to be just present there in the body of the patient, and we hope that this will be anti-inflammatory and anti-proliferative effect of T cells that will be recognizing the malignancy and tackle the problem in earlier stage patients. In earlier stage patients when there is still something that we can achieve clinically. So this is underway. First patient a month ago from my clinic enrolled. So we are trying cellular therapy with what we call, which is non-specific, but still we are entering that field. So thank you so much for your attention.
Serge, that was a great talk and just what we wanted. And in fact, you answered some of the questions that people submitted, so we gave you extra 10 minutes. Like, what's a CAR T cell? How about immunotherapy? So